Right. Hello, everyone. Good morning, good afternoon, and good evening. We are having our global webinar with people joining from all over the world. This is a virtual meeting of key populations community of practice. And today we will be discussing scaling up harm reduction interventions for people who inject and use drugs. So we have a lot to discuss during this session. First of all, we will discuss the role of people who use drugs in scaling up harm reduction programs. And then we will go through key elements of harm reduction, how it is implemented, and hear from countries what they are doing in practical sense to make harm reduction, high quality harm reduction services accessible for different subpopulations of people who use drugs. Today at this call, we will have global partners, international partners, and countries. And to begin with, I would like to say that this webinar is taking place due to support and efforts of various organizations. I will begin with Input, International Network of People Who Use Drugs, UNODC, our technical partner on HIV and drugs, Global HIV Prevention Coalition, and South to South Learning Network. Today, we will hear from the countries from Nigeria, Ukraine, and Kenya. We have a lot of speakers. There would be some time for discussion, but the discussion will be through comments in the chat. So you can post, participants can post can write questions to speakers, and then speakers will be writing their responses. The event is happening in multiple languages at the same time. At the bottom of your screen, you should have a globe symbol called interpretation, or whatever it's called in your language. And then we have translation into English, French, Russian, Portuguese, and Spanish. If your comments are coming in any of these languages, then they will be also translated. So before we move to our first group of panelists, I would like to remind all of us about several global AIDS targets that we will be discussing today. First is the target for 2022 that we all have is that 90% of people who inject drugs should have access to comprehensive harm reduction services, and not only in the context of HIV, but also hepatitis B and C and tuberculosis prevention and treatment, STIs, and other services. 80% of harm reduction services should be community-led. In that case, should be led by people who use or in other ways inject or in other ways use drugs. And also, let us not forget about the important 10-10-10 targets, the targets that tell us that criminal sanctions for drug use and drug possession for personal use should be removed, so that people who use drugs enjoyed free access to services and access to justice. So with that, I would like to give the floor to our first panel, representatives of networks of people who use drugs from two countries, from Nigeria and from Ukraine. We will start with Adam Ekpenoing from Nigerian Network of People Who Use Drugs. I will remind that we have very specifically determined time slots, and when someone is on top of the time, I will give a reminder to them. Adam, the floor is yours.
Okay. Good afternoon, everybody from Nigeria. First of all, I want to thank the South Learning for giving me this opportunity to talk about harm reduction in Nigeria. So personally, harm reduction, like the slide I sent in, concerning harm reduction is based on our intervention and implementation of harm reduction here in Nigeria, in Kwazulu State specifically. So we have been implementing for the past 1 year on harm reduction to people who use drugs. And we've been able to find out some challenges in it. With the slide I sent, you see the target we had. We're supposed to reach 7,000 plus people. We ended up reaching 3,000 plus in the slide because the needle was not actually under the community control. So that hinders the flow of the needles to the community. And if you check this other slide through here, you see some key factors that are leading to harm reduction problem in Nigeria, which shows here that 5.8% of new HIV infection in Nigeria is as a result of needle sharing. So one of the major problems we are having here in Nigeria is based on the distribution and lack of community involvement. The community in Nigeria here are actually like mobilizers. They do not really partake in the implementation, the design, harm reduction, but we only mobilize while others take care. The needles is not under the control of the community members. So sometimes you need this needle, you can't get them at the time because maybe the offices are closed and the CBOs are out of stock. Another thing too is that we don't have methadone in Nigeria to substitute for opioids. We do not also have a naloxone for overdose management. Though these are all parts of our implementation strategies and guidelines that was developed, but these are not available in Nigeria. But the key factor affecting harm reduction in Nigeria is a legal environment. Good, the harm reduction is helping. People are actually benefiting from it. It has a component of drug demand reduction. It also checks some infections within the community. The needles distributed are not sufficient. We cannot manage our overdose. We do not even have even materials for us to treat wounds at our disposal. So if you check the data submitted, you see that most of the gaps here are not that like the absence. We have enough, but we are not permitted to do this. So it leaves those things as gaps where we cannot attend to the people, or maybe this problem is coming when the person do not even have transport to visit the IP office and get this intervention. But the community here within the community and with organizations within the community have the ability to provide these services or employ people that can assist, like in mental health, legal services, the TB, the hepatitis, the X-ray, and every other things. We have community members that are capable, that are educated, that can implement these factors. But for us in Nigeria, all those things are taken out of the community. So the only part we can play is to mobilize. This has also led to lack of community acceptance of harm reduction or poor community awareness on harm reduction. So for Nigeria here, there's a package. There are good things for us to do. The people have welcomed the harm reduction, but the intervention has not achieved its impact. The greatest problem here is that we as a country here have signed a contract, have developed guidelines for implementation of harm reduction, but the law criminalizes people who use drugs. So even during your core section of trying to provide intervention, you face an harassment, you face violations from the law enforcement agency because the law is there. So one of the key problems of Nigerian harm reduction is a legal environment for us to implement the harm reduction intervention and to include community members in the implementation, not just as mobilizers. And also to make sure that these needles are within the community levels. The naloxone is within the community levels. When we need to assess MAC, should be accessible or sometimes going to be accepted by the community. Like the projection in Nigeria that the MAC clinic should be in psychiatric hospital. That is a no-no area for the community members because one, whoever goes in there will be looked at a mad person, or the drug enforcement or law enforcement agency will start hanging around there to make sure that people are picked up. But I think Nigerians are doing very well. The technical working group are doing very well. And we are implementing, if you check, you see the way we are implementing our cohort sections in different local government. We only work in one local government in Calabar due to availability of funds. So if this could be improved, I think we can have a better standard of harm reduction in Nigeria. Thank you, and over.
Thank you so much. That was straight to the point. Thank you, Adam. That was a wonderful overview of availability of harm reduction services in a country that started to provide these services relatively not so long ago. And yeah, that was important to hear about the actual gaps and about the needs of communities that are not yet addressed, including to methadone as an agent, as a drug for opioid agonist treatment, and also naloxone for overdose prevention. It would be very interesting if our next speakers, including from UNODC, BEPFAR, Global Fund, could speak a little bit about the support they are providing to countries where harm reduction services are new. Yeah, and really thank you for highlighting the issue of illegal environment and criminalization that makes the provision of harm reduction services complicated, but that also is poses a lot of risks to people who inject drugs. With that, I would like to ask our next speaker, Oleg, and he will be presenting in Russian. So the ones who do not understand Russian or do not speak Russian, please choose English in your interpretation box. Олег, тебе слово.
Доброго дня, дорогі учасники та друзі. Я перейду на іншу мову, на російську. Дякую. Наступний слайд, будь ласка.
Next slide, please. Okay.
И я хочу привести пример того, как в Украине на сегодняшний день развиваются программы снижения вреда и какую роль играет в этом сообщество людей, употребляющих наркотики и живущих с наркозависимостью. Следующий слайд, пожалуйста.
Next slide.
На сегодняшний день у сообщества людей, употребляющих наркотики, есть действительно позитивный опыт быть не только потребителями услуг программ снижения вреда, но и прямыми исполнителями. За время ковидных ограничений, с которыми столкнулся весь мир, и с момента полномасштабной войны в Украине, сообщество организовало повышение своего потенциала. Мы создали несколько ресурсных центров, а в частности 5, где развиваем комьюнити и предоставление услуг на базе этих комьюнити. Мы объединились для того, чтобы максимально покрыть географически территорию Украины, то есть представлять интересы людей, употребляющих наркотики, буквально в каждом регионе, независимо от того, оккупирован он, деоккупирован, то есть вся территория, которая покрывается географически и представляет Украину. И следующая наша тема, которая является самой главной неизменной, независимо от вызовов, с которыми мы сталкиваемся на сегодняшний день, это мы видим свет, где люди, употребляющие наркотики, декриминализированы. Они не преследуются за свое право выбора употреблять психоактивные вещества, наркополитика более смягчена и криминальное законодательство изменено. Следующий слайд, пожалуйста.
Next slide, please.
На сегодняшний день у нас есть достаточно серьезные успехи, несмотря на войну, где, казалось бы, сервисные программы для людей, употребляющих наркотики, могли бы быть приостановлены или вообще уйти на второй план приоритетности. Украина имеет достаточно серьезные достижения. Ну, во-первых, программы снижения вреда являются по-прежнему гарантированными услугами в пакете услуг для профилактики среди людей, употребляющих наркотики инъекционно. Пакет этот гарантирован государством, включает в себя 4 основных услуги. Это предоставление шприцов, это информационные материалы или консультация, дотестовое консультирование и скрининг на туберкулез. Неправительственные организации являются прямыми партнерами государственных заказов и государственных программ по профилактике. Другими словами, неправительственные организации, в том числе и под управлением сообщества, напрямую контрактируются за деньги государства. Также представители и лидеры сообщества вовлечены в диалог по планированию и реализации программ профилактики, снижения вреда, в том числе и лечения, такими как заместительная поддерживающая терапия. Развивается широкое партнерство. Представители людей, употребляющих наркотики, фактически привлечены к мониторингу и оценке выполнения программ, в том числе и Глобального фонда, и ПИФАРа, путем представления их голоса в национальных координационных советах, городских и областных, что помогает достаточно хорошо планировать деятельность и реагировать на те вызовы, которые являются экстренными в связи с войной. Мы также имеем дополнительное финансирование и поддержку донорских организаций, таких как Глобальный фонд. Напомню, что 18-20 года, 21-23 года напрямую были включены в контексте мобилизации сообщества. Напомню также о том, что Украина была приглашена к подаче заявки на 24-26 года, где впервые, наверное, в регионе сообщество людей, употребляющих наркотики, отмечены в новой заявке нового цикла финансирования как ответственные партнеры. Следующий слайд, пожалуйста.
Next slide, please.
Большое спасибо за помощь техническую. Все-таки хотелось бы сказать буквально, о чем говорит данный слайд. О том, что сообщество людей, употребляющих наркотики, прямо заявляет и будет адвокатировать расширение программ по снижению вреда, в том числе и программы обмена шприцев. Мы на сегодняшний день четко убеждены в том, что потребление наркотиков изменилось, о том, что приоритетность попадает не только под людей, употребляющих наркотики инъекционно, а в принципе людей, употребляющих наркотики, что значительно может расширить доступ к услугам и доступ к новым целевым группам, которые могут быть привлечены к профилактике. Мы говорим о внедрении шприцов с мертвым объемом, что поможет декриминализировать. Мы говорим о развитии комьюнити-центров и услуг на базе комьюнити. Мы говорим о том, что услуга не может быть дороже, чем фактически иметь нелегальный оборот или участвовать в нелегальном потреблении. Так мы заявляем о нашей экспертизе, о том, что на сегодняшний день действительно потребителю наркотиков гораздо дешевле не ходить за услугами, чем за ними ходить. Простой проезд во время военных действий за получением шприца или информации может обойтись в том числе и жизнью. Программы снижения вреда до сих пор не укомплектованы и нет в гарантированном пакете услуг доступа к программам профилактики передозировок. Государство не может обеспечить фактически дешевый препарат, который имеет достаточно хорошие доказательные принципы при передозировках, такие как налоксон. Следующий слайд, пожалуйста.
Next slide.
Мы фактически готовы быть всегда не только ответственными партнерами, поддерживать государственные программы. И тому примером является полномасштабное вторжение Российской Федерации в Украину 24 февраля 2022 года, где по сегодняшний день сообщество помогало государству на территориях, где не могло быть обеспечено гарантированное финансирование, внедрять программы снижения вреда. В том числе сообщество внедряло при поддержке партнерских организаций международных, в том числе Input, Евразийская сеть снижения вреда, на тех территориях, где государственные программы были приостановлены или имели недостаточное покрытие, внедрение таких инновационных шприцов с мертвым объемом, которое позволяло не только сделать профилактику, но и обеспечить декриминализацию. Мы также говорим о том, что услуги должны предоставляться в том числе и на базе и силами сообщества. Таким образом, сообщество должно быть вовлечено в государственные заказы все больше и больше. Мы также хотим участникам привести такой пример, что невозможны услуги, по крайней мере в нашей стране, и не будет такого запланированного охвата, если не покрывать экстренные потребности. Мы говорим сейчас о предоставлении сопровождения при внутреннем перемещении или внутренней миграции в связи с войной. Мы говорим о покрытии таких экстренных потребностей, как еда, крыша над головой. Напомню, что в моей стране на сегодняшний день разрушаются дома, гибнут люди, гибнут родные и близкие, и фактически та нагрузка, которая ложится на медицину или на неправительственные организации, которые внедряют такие программы, огромна. Но в том числе огромна нагрузка на самих людей, которые по-прежнему имеют высокий риск стигматизации и дискриминации. Ну и таким новым объектом, которым мы надеемся, что в нашей стране мы сможем похвастаться достижениями в 24-х, 25-х, 26-х годах, это вовлечение тех данных, которые собирает сообщество в рамках ответственного партнерства, мониторинг силами сообщества, где те данные, которые проводятся силами сообщества и на базе сообществ, будут включены в национальные системы мониторинга и оценки. Также мы продолжим поддерживать сообщество в виде поддержки информационных кампаний, повышения квалификации в работе в консультационных советах, дорадчих органах национального, регионального уровня. Следующий слайд, пожалуйста.
Next slide, please.
Большое спасибо за внимание. Я хотел бы закончить свою презентацию словами «Слава Україні! Героям слава!» та зауважити на тому, що ми представлені навіть при цих викликах в усіх регіонах України, входимо в 19 координаційних рад та є відповідальними партнерами програм Глобального фонду. Дякую.
Огромное спасибо. Thank you very much, Oleg. Thank you. Now everyone can switch back to English. And yeah, so we have just heard about what is happening in Ukraine, the country that has many years of successful history of integrating harm reduction services. And yeah, and the challenges, but also the ways community help to overcome challenges related to COVID pandemics, but also to war times, and the way that Ukraine continues to provide services and even scale up harm reduction services is really something that we all can learn from. It was very interesting also to hear about social contracting, and that organizations led by people who use drugs have access to state funding. And I think that this topic will be discussed again and again in some other presentations that we will hear today. With that, I will ask our next speaker, Monica Chupaji, Monica is already here. Monica switched on her video and probably her mic as well. And Monica will give us this overall overview. Harm reduction, what are we talking about here? Welcome.
Thank you, Dasha. And it's a little bit hard to just talk from the global perspective after we heard what's going on in Ukraine, and we know the devastation on the country and on the HIV services in particular. But let's try. So let's move to the next slide. So as you know, UNODC is the lead agency among the UNAIDS co-sponsor when it comes to harm reduction and HIV and health in prison. Our work is guided by the UNODC strategy and the Global AIDS strategy, and our mandate is reiterated in global commitments like the outcome document of the UN General Assembly Special Session on Drugs in 2016, and the political declaration from 2021 on AIDS. So let's move to the next slide. Because here I want to give you a little bit of an overview from the global perspective, and this is the data that is published in the World Drug Report from this year. As you know, World Drug Report is the flagship publication of UNODC that gives an overview of the global drug problem and also about the health consequences of this problem. So what the global drug report is telling us this year is that there are 48% more people who inject drugs than a decade ago. And also it's highlighting that hepatitis C remains the main cause of concern in people who inject drugs. And in this graph, you will see the cause of death to various health issues. And you can see how big is the burden from hepatitis. Let's move to the next slide. Here we are looking into the prevalence of injecting drug use in 2021, the year that is reviewed in the current report. And you will see that there are 13.2 million people who inject drugs. This is an estimation based on the reports that we received from the countries. And it's an 18% increase from the previous estimation. Can we move to the next slide? This slide is about the prevalence of the HIV among people who inject drugs. And we have 1.6 million people living with HIV estimated among the 13 million people who are injecting drugs. And this is roughly 1 in 8 people who inject drugs are living with HIV. We also know from the previous data from the UNAIDS that last year, for instance, 10% of the total new global cases of HIV were among people who inject drugs. And if you think about this, this is a small percentage of the population, 13 million, but they provided 10% of the new HIV cases last year. And that's, of course, because of the lack of services and the lack of access to services among this group. If you look at the next slide, we are talking about the prevalence of hepatitis, and here the picture is even more worrying because half of the people who are injecting drugs are living with hepatitis C, which we saw in the first slide, that is the first cause of mortality among this group. And you can see there the map and the distribution in various regions. Can we move to the next slide? So all this high burden of HIV and hepatitis among people who inject drugs is completely unjustified because we know what works. These interventions, the harm reduction interventions, were described in UN documents at least since 2009, but they were implemented in many parts of the world many years before. What you see on the screen is the most recent way of these interventions are described in the consolidated guidelines for HIV, viral hepatitis, and sexual and STI prevention, diagnosis and treatment and care for key population. And the interventions that are recommended for people who inject drugs include harm reduction, meaning needle and syringe program, opioid agonist therapy, and naloxone for overdose management. But this cannot be implemented in isolation. There are essential for impact interventions, enabling interventions like removing punitive laws and policies and practices, reducing stigma and discrimination, community empowerment, and addressing violence. There are the rest of the health interventions like access to condom, pre-exposure prophylaxis, post-exposure prophylaxis, prevention of vertical transmission of HIV, syphilis, and hepatitis, and so on and so forth. They are all there on the screen. In the next slide, We have the comprehensive package of intervention for HIV prevention, testing, treatment, care, and support in prisons and in other closed settings. These are 15 interventions that are already, that we have a lot of evidence that if implemented in a comprehensive manner will reduce significantly the transmission of HIV and hepatitis in prisons and in other closed settings. In the next slide is the recommended harm reduction package for people who use stimulants, because we've seen in the data, also in the data from the World Drug Report, that the number of people who are using stimulant drugs is increasing. The number of substances as part of the stimulants are increasing, especially the new psychoactive substances. So we developed a package, a harm reduction package tailored to the needs of people who use stimulant drugs. And you see here on the screen also the technical guide that summarizes this intervention. And based on this technical guide and on these 8 interventions, we developed a comprehensive capacity building program where we train service providers and community-led organization in, I think, if memory serves right, around 17 countries in the last 2 years. So let's move to the next slide. The needle and syringe programs are increasing in numbers in the recent years. From 2020, when there were 86 countries who had at least one needle and syringe program, in 2023 there are 94 countries who have at least one needle and syringe program. Unfortunately, very few have needle and syringe programs in prison. In the next slide, we'll see the similar graph with the opioid agonist therapy. So you see that in 2020, there were 84 countries who had at least one opioid agonist therapy program, but in 2023, we have already 90 countries, with new countries starting recently, like Egypt, for instance. These numbers look good and they are encouraging, although we are still talking about half of the countries who are, or less than half of the countries who are reporting injecting drug use. The problem is that the access to these services remains really low. And in the study that was published recently in the Lancet by the University of New South Wales, we saw that actually the number of people who are living in countries with high access, with high coverage of harm reduction programs, meaning needle and syringe program and opioid agonist therapy, actually increased very little. 10 years ago, there was 1% of people who inject drugs who were living in countries with high coverage. This year, it's just 10 years after, with all the efforts, is 2%. And there is also a small increase in the number of people accessing opioid agonist therapy from 5% 10 years ago to 8% this year. So you see, with all the efforts that we made so far, the access to services remains low. And there are several explanations for this. Can we see the next slide? The major barrier accessing harm reduction for people to access harm reduction interventions are, of course, the criminalization of people who use drugs. They have to trust these services to access them. Then there are the multiple intersecting forms of stigma and discrimination experienced by people who use drugs, including while accessing health, legal education, employment, and social protection services, or when interacting with law enforcement. Then there is a lack of policies and programs that can effectively increase the access to opioids for medical use for people who use drugs. The lack of training and awareness of health professionals and service providers, limited financial resources, cultural attitude that are limiting the availability. You see, these programs that exist in some countries are sometimes very fragile, and they depend very much on the political context, the political changes, the availability of funding, the changing in the funding trends, and also the changes in the legislation in the respective country. So I will give in the next slide a couple of examples of what we did to support the increased access to opioid agonist therapy. We published a guide recently, a technical guide on establishing and delivering evidence-based high-quality opioid agonist therapy services, because we see an increase in number of countries who are starting to give access to this therapy, but also countries who are scaling up the existing programs. In the next slide, you will see a couple of examples of the capacity building program that was put in place. And last year and this year, we reached over 10 countries, I think, with this training. We did study tours, and we supported in every way we could countries who are starting or countries who are scaling up to reach more people and to provide, low threshold programs for their clients. In the next slide, we also try to build on the lesson that we learned during the COVID, because an interesting thing that happened during the lockdowns was that many countries change the way they were delivering the opioid agonist therapy and allowed take-home doses, because people could not go out of their houses. They could not go to the clinic every day, and all the clinics were not open all the time. So in many countries, take-home OAT worked very well. The involvement of the community in the delivery of the services, including needle and syringe program and OAT, proved to be essential in to ensure the continuation of the services. So we saw that these are useful lessons that should be shared and applied also in post-pandemic situation, when people are not locked in their houses, but they still can continue to do their work and their life without going every day to the clinic to take their methadone and take the medication like other medications are prescribed for a longer time. In the next slide. So this is what we did for to support the increased access to the opioid agonist therapy and needle and syringe program. And now I would like to talk about the financial situation. And I borrowed some slides for our colleagues from the Harm Reduction International, because they published recently a paper on the situation with the funding for harm reduction. And what they found out was that actually only 5% of the needs are covered at the global level to bring up to scale harm reduction programs. They also saw that there was a 30% decrease in funding in the low and middle income countries in between 2016 and 2019. And that the majority of funding are coming from the international donors, and the domestic sources still need to be increased. So if we look at the next slide, we will see that actually the harm reduction is still reliant on international donors. And the involvement of the international donors is crucial for harm reduction programs in low and middle income countries. But the number of donors is not that big. We have 5 international donors that are providing funding over 5 million, and 5 international donors that are providing smaller funding between 100,000 and 5 million. Global Fund and PEPFAR remain the larger international donors, accounting for 72% of the donor funding. But we also see that with the continuous crises that are emerging so often, the donors shift away from middle income countries because their attention is caught on, emerging crises that require support immediately. Criminalization and punitive policies remain a barrier for people to have access to funding and to increase the access to harm reduction. In the next slide, colleagues from the Harm Reduction International look at the domestic funding, and they saw that 38 countries reported in 2019 to have domestic funding for harm reduction. But this funding still needs to have greater transparency, still have to increase the allocation at the subnational and provincial level, and most important, still need to invest more in the community-led responses, because these are crucial to move forward and to bring up to scale the access to harm reduction. And the last slide. Well, some ideas for the way forward on how to ensure the needed funding for harm reduction is, of course, having in mind that the international funding and the domestic funding is constantly shifting, to optimize the existing funding, to advocate with the governments to scale up the domestic government funding, to maintain and expand as much as possible the international engagement, and of course to come with new ideas on how to optimize and secure funding for the harm reduction intervention. Thank you very much.
Thank you so much. Thank you so much, Monica. It was really great how you managed in less than 20 minutes discuss the basics and not the basics, the challenges and the way forward. You have a couple of minutes, and there is an interesting question in the chat. I don't know to whom it's addressed, so I will be maybe asking all of the speakers if you have something about intersectionalities. So what do we know about people who inject drugs and are also sex workers or men who have sex with men? Is UNODC addressing their needs or helping to address their needs on the country level through training, technical support, population size estimates, whatever you can say here?
Yes, of course. I mean, I mentioned briefly our work on people who do not inject, people who use stimulant drugs. And we can go back to that slide and show again the stimulants guide. So we developed this stimulant guide. This was an idea that emerged in our civil society group on drug use and HIV. This is a group that was established more than 10 years ago and has representation from all the drug user networks, all the regional drug user networks, and also the global network. So this is the slide, yes. So this publication was developed by a group of people with lived experience on stimulants use. And then based on this, we developed a capacity building program. I have to give credit to Matt Southwell, who is the brain and the heart behind this initiative. And then we went in most of our high priority country, and we built the capacity of service provider, but most importantly to the communities to deliver these services. And when I speak here about the communities, I'm talking about networks of men having sex with men, networks of sex workers, of transgender, people who are involved in chemsex. So when you talk about stimulants, you have to think about a very large group of people, and actually there are representations from all the key population, and try to see how you can tailor these interventions to their needs and also how to reach them where they are, because there is, as we saw in more than 3 years now on rolling out this capacity building program, and also advocating at the country level to establish services for people who use stimulants. The way we need to meet the needs of the people who are using stimulants is different from the traditional harm reduction programs where you will have a drop-in center and people will come and take the needles and or access the methadone or buprenorphine treatment. So it requires a change in thinking, a change in approach, and we saw this happening in a couple of countries. I just came back from Indonesia where we did a training for the organizations, a group of organizations in this country who are looking on how to expand their services for people who use stimulants.
Thank you. Thank you very much, Monica. And there are other questions that you will see in the chat box. By the way, the question is a very interesting one from South Sudan. What technical support can be offered to countries which are just starting to implement? What kind of technical support to develop national guidelines or standard operating procedures can be offered? Maybe we'll have a little bit of time to discuss this as well. If not, we will also be happy to reach out to participants with, possible modalities of technical support. And
sure.
now,
we, in collaboration with our colleagues from the World Health Organization, we supported the development of standard of practice and of guidelines in many countries that started recently. So they can, colleagues from the South Sudan can reach us separately and continue. So I won't take more time. Thank you.
Thank you so much, Monica. And I hope that this is the start maybe of discussion, not its end. So
of course,
let us now switch to a even more interactive part. And this is Mentimeter. I believe people who lived through COVID pandemics already know Mentimeter. If you don't know how it works, please look at your screen. On the right side of the screen, you have a QR code. You just use your cell phone, and you just use it to the photo, and then then there is a link to the web page, or you go at menti.com and use the code, all 8 digits you see here, and you will come to our Mentimeter page. And there is one question we would like you to answer. What are the barriers to scaling up evidence-based interventions for people who use drugs, or in particular, people who inject drugs in your country? Yeah, and thank you, Karabo, for placing also a link into the chat. So yeah, I will give you all a little bit of time. And I will also use Mentimeter. I will also use this link to say a couple of words, up to 200 characters. What are the barriers? And I welcome everyone to do the same. We will not know who is the answer coming from, so please be open, be frank, and be specific. Okay, we see here things related, barriers related to policies, cultural beliefs, stigma about drug use, lack of political will, criminal laws. Criminal laws is, coming several times, I can see it. Lack of information. By the way, you can also send your messages in whatever languages you want. I mean, not in whatever languages, but in, the languages that we have here: French, Russian, Spanish, Portuguese. Lack of guidelines, financing, lack of data. I've also saw low community engagement. Criminalization is coming up again. The legal environment does not, the legislation does not differentiate between people who use drugs and traffickers. Stigma. No governmental support to harm reduction services. A lack of engagement, again, of networks of people who use drugs that are not strong yet enough within the country context. Let us take 30 more seconds to add. If anything's missing from the list, please don't hesitate to send one more message. Limited funding, stigmatized communities. fear of arrest is a major barrier to harm reduction services. Okay, so what comes clearly here is lack of empathy for people who inject drugs, cultural and religious beliefs. So we are talking about a group of factors that hinder the development of harm reduction services. So the first is cultural beliefs, social norms, and related stigma of people who use drugs, criminal sanctions against drug use or drug possession for personal use, then low availability of data about this population, about the population of people who use or specifically who inject drugs, low programmatic response, no support from the government for harm reduction programs, and the funding. These are the challenges which we face today. And with this, global picture of the issues that need to be overcome, we are moving to our next session, practical approaches to implementing harm reduction programs at scale. And we'll have two country examples, Kenya and Ukraine, to actually show us what is done on the national level to address the challenges that we just placed, on screen through Mentimeter. Timothy Kilonzo from Kenya, you're welcome. You have 10 minutes and I will give a signal, when 10 minutes are over. Please.
Thank you, Dasha, and really appreciate if we can go to the first slide. And I will be making this slide on behalf of Kenya and on behalf of my CEO, National Endemic Disease Control Council. And if we can go to the next. As we are discussing this, remember, most of the countries, drug and substance abuse has been criminalized. However, they still spread use of the same. And with this, we have a proportion in Kenya that the proportion of the men who use and abuse drugs are higher than that of women. As you can see, is 30.7 compared to 6.4 with regard to women. And alcohol is the highest drug that is being used within the Kenyan context. And as you may be aware, Kenya has various regions, and most of the regions that have been affected, the highest region is referred to as the Western region. Next. Next slide, please. And with this, the HIV program or the HIV response is anchored under a 5-year strategic plan, which is what we refer to as the Kenya AIDS Strategic Framework, which again recognizes the issues to do with drug and substance abuse. And with these, our main objectives within that particular framework is to ensure that at least by 75%, we have reduced HIV infections by 75%. And with regard to harm reduction, we have also eliminated the aspects of viral hepatitis, as well as also reduction of stigma and violence up to a point of less than 25%. And if we can go to the next slide.
I'm sorry, Timothy, can I ask you to speak a little bit slower?
All right, thank you, Dasha. So with this, we have our HIV situation in Kenya, and the HIV prevalence currently in Kenya is at 3.7, putting in mind that Kenya has about 54 million persons living within the country. And out of these, 1.3 million of them are living with HIV. And as we can see, with regard to the new HIV infections, majority is emanating from the persons between the age of 15 to 24. And this is also the population that is highly affected by the drug and substance abuse. So with this, there's a focus on the adolescent and young persons. And also with this focus, let us also be noted that at least within 6 people, six people in Kenya, one of them have ever used and or misused a particular drug. Next. Next slide, please. All right, so with these, if we are looking into the persons who inject drugs in Kenya, their prevalence, the HIV prevalence is 6 times higher than that of the general population, putting in mind the general population is at 3.7, and for the people who inject drugs is at 18.7%. And this is emanating from a number that is 26,000 673 persons who inject drugs in Kenya, and they are spread all over the region, all over the country, but more so the coastal region and the central region, which we have the Nairobi County, as well as part and parcel of the western region. So most of the numbers of these particular individuals emanate from the coastal region, and the assumption may be, and I use the word maybe, would be courtesy of the route that the oceanic route that most of the drugs are transported through. So looking into that, next slide, please. Again, what is the journey of the harm reduction program in Kenya? One, back in the year 2008 to 2010, those 2 years, we recognized people who inject drugs as a key population and as a key group that needs to be focused with regard to HIV response. And with these, in our policies, we recognize them. And then thereafter, we also engaged into undertaking research and surveys, whereby these gave us the development of various guidelines, evidence-based guidelines for interventions for the people who inject drugs. And with that, we went ahead and scaled up to a component of coming up with opioid substitution therapy facilities, and where we used methadone as OST for the people who inject drugs. And with these also, we went to an extent of now bringing on board, back in 2016, 2018, bringing on board the combination prevention approaches, where we have behavioral, biomedical, and structural interventions, which ensured that we have most of the people who injected drugs having access to HIV services, among other services. And thereafter also we went to scale up, putting in mind that the numbers were increasing courtesy of them coming out, and there being an enabling environment for them to come out and access services. And in 2018, 2022, we scaled up these particular services. And now we are focusing on the legislative agenda, also putting in mind that we've been indicated that we need to reduce those criminal policies at least by 10%. Less than 10% countries should have that, and Kenya is really on the right track in looking into the legislative agenda to ensure that we have achieved a less or no punitive measures within the country. Next. And with this, the harm reduction program is really anchored under a very good and a strong policy and legal framework, from our legal framework in terms of the constitution to the guidelines and the policies that we implement. Again, it is also recognized or anchored within our HIV Prevention and Control Act, which again is under review, and which I'll have a discussion in the following slides in terms of what is happening with regard to the legislative agenda. Over next. So in terms of characterizing this particular individual in Kenya, this particular individual who is injecting drugs, we can put some component of social challenges, social and economic challenges within them, as well as the challenges that they face with various law enforcement agencies. And more so, when you look into this, 11% of them are below the age of 18 years. That is a big number that needs to be focused, 11% of the 26,000. And then 15% of them are women with a higher vulnerability compared to the men. And then 31% of these individuals who inject drugs have ever been confronted by law enforcement, and this is majorly being arrested and or being put into prison. And then 81% of them have really been into prison courtesy of the rulings and the sentences within the judicial system. And 7% of them have ever injected drugs within prisons. That tells you that we really need these programs within prisons. And the 61% of these who have been in prisons have ever shared needles and syringes within this particular prison, again, which it becomes a breeding ground, and hence the reason as to why we focus on various programs within our prison facilities or correctional facilities. If you can move to the next slide. So with these, again, in terms of scale up, courtesy of these engagements, we've been able to increase our engagement or our reach to 72% of the people who have been injecting drugs, compared to back in 2014, where we had about 6,000 persons who have been injecting drugs. Up to right now, we are at 22,000, which means at least courtesy of the environment, we can see now people are coming out to be able to access these harm reduction services in the country. Next. Again, with this particular proportion, you can see, and I apologize for the slides, the last two where we have the sex, men and women. It is the opposite, men at 95%, women at 89%. So with these, as much as we say most of the men are, most of the people who use drugs are men and boys, we have also seen an increase of the women who are using drugs. And in these, they are more susceptible, and they're in terms of vulnerability, they are at a higher risk in terms of engaging into drugs and substance use, because some of them might be also sex workers, some of them might be also doing other risky behaviors that might put them at a higher risk of contracting and or transmitting HIV. Next. So again, by the end of 2017, in terms of needle and syringes, we had about 88% of men and women who had already accessed this particular product. We have a good program that undertakes needle and syringe program, and we're in the process again of ensuring that at least this gets to 100%, putting in mind that we've been given again a target by 90% of all the people who inject drugs must have at least be able to access services, including needle and syringe. So at our country, we are at 88%, and we intend to ensure that we create another environment or create an enabling environment that will ensure that this particular component has been reached to that particular percent of 90 as per the targets given. Next. So in Kenya, we have the OST program, that is opioid substitution therapy, and where we use the product known as methadone, liquid methadone, using which is delivered under the medically assisted therapy facilities. And in these, we have the program which started back in 2014, and we are now focusing on all people who inject drugs, and we are doing decentralization in terms of taking it to the prisons, and as well as using the mobile vans. And with this, if you can go to the next, you can see the number of MAT facilities, medically assisted therapy facilities that we have, and put in mind, 3 of them are established within prison facilities, and we have 14 MAT facilities in 7 counties, and we intend to now ensure that at least we have scaled up our services. Next.
I'm sorry, yeah, the 10 minutes are over. Please wrap up.
All right, if I can go to this. So if you can look at what you have on the screen is a legal notice that has already, courtesy of advocacy, our legislative arm has already put some components of harm reduction within the legislative agenda, and we are now in the process of ensuring that at least by the end of the year, we have a legal policy framework that will support harm reduction, and for it to be focused in our Primary Healthcare Act. And if we can finalize going to the next, again, we have various engagement of the people. We ensure that they are in front and they are part and parcel of the teams that implement harm reduction. And we have more than 35% programs within the country run by the key population, including the harm reduction program. Engagement of stakeholders, again, is a key thing that we have been focusing on. And these stakeholders will include policymakers, law enforcers, by doing advocacy, sensitization, and trainings towards them, and also ensuring that we have a multifaceted, multi-sectoral engagement of all stakeholders in achieving our goals. In terms of legislative agenda, we are currently in the process of ensuring that we have a panel that will be constituted to ensure that there's alternatives to incarceration, and we are no longer criminalizing aspects of drug and substance abuse. As I conclude in my last statement, we are reviewing our HIV Prevention and Control Act, which again will see the inclusion of needle and syringe programs as HIV prevention for the people who inject and abuse drugs, and this will eliminate the aspects of hepatitis. Over and thank you.
Thank you. Thank you so much, Timothy. I know that 10 minutes is really not enough to describe this journey that Kenya has, had from the very beginning of its harm reduction programs until today. I really loved the map, and the question that was from South Sudan, or maybe there was other countries, where harm reduction are only starting. Please use Kenya, not only Kenya as example, how you roll up services with what we start. Nothing happens in one day, nothing happens in 1 year. But the sooner we start in a more systematic way, the better results we achieve in terms of HIV prevention and other health outcomes. Our next speaker is Tatiana Dashko. Tatiana is from Ukraine, a country with really, an impressive story of harm reduction. and impressive results. Tatiana, the floor is yours.
Thank you very much, Daria. Good afternoon, dear participants. It's exciting to be a part of the event and taking over from Oleg Duma, who already spoke on the harm reduction interventions in Ukraine. Indeed, Ukrainian program is a well-established one, and out of the estimated 300 people who inject drugs in Ukraine, about 65% have been receiving services at the governmental cost before the war. But then came the war, early 2022. Next slide, please. As for now, about 20% of Ukraine's territory is occupied by Russia. 15 million people have left their homes. Some were left outside of Ukraine, and 8 million have been displaced within the country, from the war zone to safe places. About 1 in 10 medical facilities has been either damaged or destroyed by war. Next slide, please. Here on these smaller photos, you can see the office of one of our partners, Red Cross Society in Kherson, what it looks like now after it has been shelled by Russia. So there has been a massive change in how we operate. But to say the truth, there have been very difficult, but also some of the very important adjustments and developments in our harm reduction program. And I'm happy to speak about them. Next slide. First and foremost, it was very important for us to sustain the services that have been provided to a broad range of communities, over 200,000 people who inject drugs. And I'm very pleased to say that we were able to fully maintain the program, and all of the people who have been reached before the war have been receiving HIV prevention, opioid agonist treatment, TB, viral hepatitis services. We had to change our work to become more mobile because in the areas which are close to the front line that have been occupied and then deoccupied by Ukrainian armed forces, there are hardly any healthcare facilities or harm reduction services available. So we used vans to deliver services to people there. We also have become more digital, which means that we have delivered more services online using online consultations, as well as automated messages, as well as artificial intelligence. We had to become agile to address the emerging needs. When people relocate, they have new needs related to the quality of drug, related to their settling in new places. So we had to be like that. And we had to be relevant, of course, because the people's daily lives were not only related to injecting drug use, but also settling in new places, finding a place to live and food to eat. We had to innovate, and I will share some of the innovations, and well, we're happy to be sharing with other countries. Now I will illustrate you what are the changes that have happened. So please, next slide. Opioid agonist therapy in Ukraine is a well-established program, and before the war started, we had about 17,000 people who inject drugs on OAT. You can see the monthly chart here, which shows the period. You can see where the red chart is. This is the month, the March after the war started. So we've seen a drop in patients on OAT, but we very quickly were able to, please go back, to bring people back to the therapy, and we're also able to increase the number of patients on opioid agonist therapy. So now we have over 20,000 people on OAT. This is very much thanks to the fact that we give take-home doses of OAT. Therefore, people can have up to 10 or 14 days supply of OAT with them. Next slide, please. We have used 50 mobile clinics to actually deliver services to people in fragile places. Over 50,000 people who inject drugs have received such services through mobile clinics last year. We've also been delivering methadone using these mobile vans. We are able to provide a core and extended package of services, which include OAT, psychosocial support, testing for HIV, for hepatitis, as well as delivery of IRT. Next, what was also very important that in Ukrainian program we had important innovations such as long-acting depot buprenorphine available. We plan to have 500 people on LADB. Now we have about 200 people who are receiving LADB, which is so important when people are in an unstable situation. Next slide, please. When people are moving, and actually millions of people have moved within Ukraine and outside of Ukraine, the contact with someone who could lead you on where you can receive your methadone when you have relocated from Ukraine to Poland, for example, was very important. So we have established an online service, Help Now, which has been addressing the needs of people on the move. So it was using the database of services available in neighboring countries, as well as providing a person-to-person support and where services can be accessed when the person moves. So we have provided almost 2,000 consultations related to opioid agonist therapy to support people who move from Ukraine to Poland or to Germany to get linked to their OAT in the receiving country. Next slide, please. We have also promoted online ordering of test kits and their dissemination using postal services. So these are the kits which have syringes, needles, HIV, oral tests, lubricants, booklets, alcohol wipes, combo tests, which also include hepatitis B, hepatitis C, and syphilis. And so we've been distributing them widely, and we have delivered 5,000 such health boxes during the 9 months of 2023. Next slide, please. As recreational drug use has been increasing in Ukraine before the war, it continued during the war. So we also offered additional services for people who practice chemsex. Apart from what I have listed already, we have also been distributing drug checking kits using this mailing service. To support people who are buying their substances from new dealers because they have moved to new places. This has been very, very important. An important innovation that we are planning next year is treatment for ADHD for people who use stimulants. We will be piloting a program in several regions of Ukraine using methylphenidate medication. Next slide, please. Again, due to the changes in people's regular drug use, their movements and procurement from new dealers, so the substance was not always known or clear in its efficiency. So we prevented overdose. We have procured naloxone and distributed it we distributed over 75,000 ampoules to naloxone, as we've seen reported overdose increase during this wartime. Next slide, please. We've been supporting other needs of communities because when people have nothing to eat, it's difficult to provide them with a syringe or condom only. We've been supporting people's relocation to new places. They're kind of sometimes buying food or some other first-hand necessities. Next slide, please. We have also supported shelters for some of the community members who have relocated to new places. Next slide. We've also used artificial intelligence in our work to help us to locate new cases of HIV infection. I'm close, these are my last slides. So we have trained artificial intelligence on 300,000 clients' records to teach it where the greatest risks of HIV are. And this model has helped us to predict people's behavior who have most risk of HIV and to help us find those cases. And my last slide, we're happy to be engaged in international programs which bring innovation on harm reduction responses. UNITAID project focuses on hepatitis C models of care, community-based hepatitis C diagnostics and treatment delivery, and Ukraine is part of that. well, LADB program extension, which I have already mentioned. So I would like to thank people for supporting Ukraine and for supporting our programs. You have seen we have done pretty well. Thank you.
Thank you, Tatiana. And this is an incredible example of resilient harm reduction, resilient communities in such hard times of the war. The pictures were heartbreaking to see any buildings destroyed like this, but harm reduction services that, you know, received within that were got supported to evolve in Ukraine to be actually destroyed. And but the fact that harm reduction services in Ukraine continue to save lives and to address various needs of people who use drugs, to use innovative approaches, not only to sustain the previous level of services, but even to increase it, this is something that, you know, we witness today. Yeah, and that's a great example, even though the circumstances.
Thank you.
Yeah.
Thank you very much.
Thank you. And yeah, so with that, we move to our last panel of international donors. We have the Global Fund and PEPFAR. And I welcome Susie McLean to speak. And Susan, you've heard a lot of things raised today. New countries just starting harm reduction. Countries already started harm reduction, but opioid agonist treatment or naloxone or other programmatic components still not available. So what the Global Fund does today to address these issues, what kind of, you know, what should we expect in 2024, if I may ask you?
Hi, Dasha, and thanks for the question. And hello, colleagues. It's a great question. One of the things that we can all expect is that the Global Fund will be funding harm reduction in a greater number of countries. So one of the things that that says to me is that patterns of injecting drug use are changing and growing. I mean, I think we saw some of the data from Monica's presentation, but yeah, one of the assumptions that we're working from is that the need for harm reduction is expanding, and the Global Fund expanding its HIV prevention investments. But I think most of us can see that there's not hugely expanding resources available for HIV prevention, including harm reduction. So, in one sense, the trend is a good trend, and it's great that in countries where patterns of injecting drug use amongst young people are growing, that countries are kind of forming their response around harm reduction in an early stage. I think that's really promising. But I think a general kind of question or problem for all of us is how to expand harm reduction access to address those gaps that Monica's data refers to address those gaps, to address the global target that says that 90% of people who inject drugs should have access to HIV prevention, when the resource envelope is not expanding substantially. One of our colleagues has already mentioned the need to improve advocacy efforts to increase domestic funding for HIV prevention and harm reduction. But also, too, I think there's some really interesting things to reflect on from Tanya's presentation just now. So this is, you know, as Dasha, you mentioned, this is an example of a resilient program. This is not really a program that it's kind of not a classic sustainability transition program, although it was before the war. But I think one of the things that we can all learn from that is from the Ukraine example, is how to think about more sustainable, flexible, agile, lower cost harm reduction programs that will have a greater chance of being sustained into the future. So, for example, a really excellent example is the delivery of methadone or OST programs via using take-home dosing methods. So I think all of us can see that establishing a methadone program that requires all of the patients, all of the users to attend every single day has quite substantial resource implications. But methadone programs that offer take-home dosing to substantial numbers of people who are on the program will be more efficient. There'll be less staff time needed, less time taken by service users to get to the clinic, and a more person-centered, more user-friendly approach to service delivery. So it's examples like that we're looking for, and I think that we're collectively, as a movement, we're looking for to kind of see how much further we can stretch the harm reduction dollar. And to ensure that harm reduction services survive for the long term, especially as we can see that prevalence of injecting drug use increases rather than decreases. Just wanted to make it super clear, and I know that there's not a lot of time, so I'll just be brief, but just to make it super clear, Global Fund's commitment to investing in harm reduction as part of its HIV prevention commitments that are very clearly articulated in our new strategy. And people can see that commitment reflected in the HIV information note, our main HIV funding guidance, plus also our harm reduction technical guidance, and to note that harm reduction is specified as a program essential alongside, for example, condom programs, alongside PrEP access. And so one of the things that we've tried to emphasize with our program essentials is there are many, many things that actors can do under the heading of HIV services. People with HIV and people who need HIV prevention have many, many needs. But what we've tried to do with the program essentials is to specify the things that are really most critical. And just to note that harm reduction services, people who inject drugs, are one of these program essentials. So, we're pleased to see more countries applying to the Global Fund for resources for harm reduction. I suppose just concerned, I think, that the need for harm reduction grows. And so therefore the need to fund harm reduction grows when resources for HIV prevention are increasing, certainly from the Global Fund perspective. But our ability to increase our investments in HIV prevention, as many of you know, depend on our replenishment processes and the kind of appetite globally to keep funding HIV prevention. So there's a few uncertainties in the future, and so just to come back to my first point, looking at service delivery options and looking at the provision of harm reduction in ways that are most efficient and most likely to reach most people is one of the things that we're really interested in. And then just to finish, I think for those people who are on as part of this webinar who are from countries that are in the early phases or the startup phases of harm reduction programs, it will be interesting to think about how we can together develop service delivery approaches that learn rapidly from some of the lessons that have been learnt in countries like Ukraine and Vietnam that are about efficiencies, getting more services to more people, and just kind of throw in to that set of questions things like, I think we should be questioning, for example, how sustainable it is to have separate and standalone methadone programs. That's an example for me of something that I think is both appropriate in some settings and important in some settings, but also raises questions about how vulnerable separate and non-integrated services are in the long term. So that's all I'll speak about now. We need to wrap up soon, and we're keen to hear from our colleague from PEPFAR. But yeah, just in summary, my most important points are the Global Fund continues to be very committed to funding harm reduction and HIV prevention for people who inject drugs. There are some greater flexibilities now in terms of our ability to fund hepatitis C treatment for people who use drugs, but also that we're really interested in continuing a dialogue with many of you about efficiencies and models of service delivery that reach more people with the available resources. Thanks. That's all.
Thank you. Yeah, thank you so much, Susie. Yes, with increased demand for harm reduction services, increased number of countries that are going to start providing harm reduction services, but almost flat amounts for HIV prevention, we need to look into efficiencies. And we know where to look for efficiencies. These are community-led responses. These are less complicated modalities of service provision. What we heard already from Ukraine here in the morning webinar, that was a presentation of Vietnam take-home doses of methadone really, help us decrease unit costs. And there is a lot to talk about it. But now, because yes, our time is coming to its end. So, but we have one more wonderful speaker from CDC, Ansley Lin. Ansley will talk more now about what PEPFAR is doing to support harm reduction. And yes, and Ansley, please, the floor is yours, and I will be up here in 6 minutes to not, for a note to tell you that the time is coming to its end.
Sure, no problem. I'll try to stick to the time. Can I get the slides? Yeah. Thank you. All right. So as mentioned, I'm Ansley Lin. I'm with CDC, the U.S. Centers for Disease Control, but I also fall under the PEPFAR umbrella. And so I'm here to just provide a few reflections to answer a few of the questions that Daria posed about PEPFAR programming, including harm reduction services for people who inject drugs, which is an important beneficiary group within our global key populations programming. Next slide. So in the 20 years of PEPFAR support of HIV programs globally, it's estimated that 25 million lives have been saved across more than 50 countries. While PEPFAR has supported life-saving HIV treatment for about 20 million adults and children since 2003, it's also supported HIV prevention services in these countries. Of interest in today's webinar is the impact PEPFAR has had in funding harm reduction services for people who inject drugs in a subset of PEPFAR-supported countries. Equity for priority populations is the first strategic pillar in reimagining PEPFAR's strategic direction to end the HIV/AIDS pandemic as a public health threat by 2030, as PEPFAR supports harm reduction interventions to achieve equitable HIV outcomes for people who inject drugs. Over the 3.3 million key populations served in fiscal year 23, around 10% were PWUD who benefited from harm reduction and outreach services, in addition to HIV prevention, care, and treatment programs. Next slide. All right. So on the left side of this slide, we provide the number of PWUD being reached with at least one HIV prevention intervention. From fiscal years 2021 to 2023, PEPFAR has reached between 290,000 to 385,000 PWUD with prevention interventions. And these interventions for PWUD and other KP include, but are not limited to, offers of HIV testing services, condoms and lubricant, referrals for PrEP, targeted information, education, and communication materials. And then for PWUD specifically, this can also include referrals to medication-assisted therapy, or MAT, also called opioid substitution therapy, OST, and offers or referrals to needle and syringe programs. So while PEPFAR doesn't actually provide the funding specifically for needles and syringes, we do work closely with the Global Fund, who does fund these commodities to provide this critical harm reduction support. On the right side of this slide, we show the number of PWUD being initiated on PrEP during fiscal years 2021 to 2023 through PEPFAR. Between those years, PEPFAR initiated between 20,000 to 32,000 PWUD annually on PrEP. Next slide. So again, between the fiscal years 2021 to 23, PEPFAR support for MAT or OST programs has shown substantial improvement. The number of PWUD on MAT for at least 6 months has increased from roughly 25,000 in 2021 to approximately 41,000 in 2023. PEPFAR supported programs have often exceeded their annual targets for supporting PWUD on MAT, and as of 2023, on the far right bar, PEPFAR programs have surpassed their target by reaching 160% achievement. Next slide. I also want to draw your attention to the strong HIV clinical cascade results for PWUD in the most recent fiscal year for 2023. The HIV clinical cascade for PWUD shown here indicates that in 2023, of the 16,000 PWUD who tested positive, which is the blue bar, the PWUD who tested positive across PEPFAR programs, 91% initiated life-saving HIV treatment, which is the orange bar. And then finally, of the 54,000 PWUD currently on ART who had a viral load test done, 96% were virally suppressed. That's the yellow bar. Next slide. So I previously mentioned the MAT or OST achievements across PEPFAR, but this slide provides a little more context into which countries receive PEPFAR-funded OST. PEPFAR currently supports OST in India, Mozambique, Kenya, Kyrgyzstan, South Africa, Tajikistan, Tanzania, Uganda, and Ukraine. The countries listed here in orange or highlighted in orange on the slide. And then it's important to point out that one country, Vietnam, is an example of a country with early OST support from PEPFAR that successfully transitioned its entire OST program to the national government several years ago. PEPFAR is also expanding its support for harm reduction in fiscal year 24, as several countries have plans to support OST and are working with their government and other stakeholders to move this forward. And so some of these countries include Botswana, Ethiopia, Namibia, Zambia, and Zimbabwe. Next slide. And so I think we've received a couple of questions about what newer programs or programs that would like to start doing some of this work where they can kind of start. And so one of the things that we've been engaged in is country-to-country learning exchanges. So PEPFAR has been supporting these exchanges and engaging to share knowledge and best practices from PWUD-focused programs. And so during these learning exchange visits, program staff from PEPFAR-supported agencies in each country, as well as their implementing partner staff and government stakeholders, will tour community and government facilities and observe harm reduction outreach, testing, and prevention treatment services that are being provided to PWUD. They gain firsthand knowledge about their program startup and operations, as well as challenges and successes. And they get to also engage with PWUD and other KP community members to understand the impact that these essential services have on people's lives and hear about program needs and priorities directly from the clients. And so on the slide listed, we have some of the exchanges that have already taken place, including Uganda to Tanzania, and then we have some future planned exchanges, including Zimbabwe to South Africa, Malawi to Kenya listed. And I think just to wrap up, since I know we're almost at time, I just wanted to say that, I've presented a few achievements from PEPFAR supported programs, and I know like it's a really short time. Everyone has a very limited time to talk about these things, but, PEPFAR is, we understand that many of the countries, the legal, political, and social environment presents many challenges to all of our work for PWUD and other key populations, but PEPFAR, as Global Funded mentioned too, PEPFAR also remains committed to supporting this work as it aligns with our mission of saving lives and preventing HIV infections and controlling the HIV/AIDS pandemic globally. That's it. Back to you, Daria.
Thank you. Thank you so much. This is really impressive, this long story of PEPFAR supporting various elements of harm reduction programs, in particular opiate agonist treatment, which often meets political resistance. So this ongoing support is really important for countries to start, scale up, and also, have sustainable opioid substitution treatment or opioid agonist treatment with methadone or buprenorphine. And yeah, so I know that we are a little bit, behind the schedule, and I'll try to wrap this really rich discussion in just 1 minute. And what I can say, yes. And by the way, I want to ask everyone to look at the chat. We had such a rich discussion there that I almost would want to read all the questions and answers, but just we don't have time. You can do it. You can stay a little bit longer if you have time and look at the questions and answers. The challenges that harm reduction development programs faces today in African countries or in Global South in general, yes, there are a lot of specifics that we need to discuss on the global level and through South to South exchange. I would like to mention that just last week there was a meeting led by Ghana mission, meeting in Vienna to prepare African countries to the next CND session and to discuss harm reduction, decriminalization, or alternatives to criminalization of drug use. Processes are happening, political dialogues are taking place, and I think today we really witness the increase of harm reduction in terms of the number of countries engaged, people served, variety of methods improved, but also barriers, political, modalities in which we discuss harm reduction as well. Thank you very much. And yeah, we'll see you, I don't know, next time at another webinar of Communities of Practice. Thank you all. And thank you again, the speakers, organizers, and interpreters. I hope we didn't make your life too complicated today. Thank you.